All right, you're certainly getting a potpourri of different subjects today, aren't you? So the topics we'll be discussing are the anatomical basis of normal rhythm and tachycardias. You may be surprised that you don't pick up your transducer right away when confronted with a fetus with tachycardia, but you actually get some history. And then we'll talk about evaluation and diagnosis, and then get into the nitty-gritty of the management and treatment. So this is a very basic slide, but just so we're all on the same page, conduction in the normal heart starts with the SA node, which is this pacemaking region of the heart, and is in the right atrium. That initiates atrial contraction. We can detect that by the P wave on the ECG. And in fetal work, when we use our pulse Doppler, you'll remember from yesterday, Elena showed us beautifully the E and A wave of mitral inflow, and that A wave corresponds to the P wave on the EKG, which is when the atrium contracts. The electrical system sign is then sent down to the AV node, which slows it down, and there's a slight delay before the ventricles contract, and that's our AV interval, which is the measurement from the beginning of the P wave to the beginning of the QRS on the EKG, and similarly from the beginning of the A wave to the beginning of the ventricular outflow, the aortic outflow wave on the spectral Doppler. And then the impulse is transmitted down to the ventricles contract, which we see as the QRS on the EKG, and is the ventricular output via the aortic valve on the inflow-outflow Doppler. So tachycardias appear at first glance to be a little bit confusing because they're really two different mechanisms, and I'm going to try and simplify them as much as possible. The first mechanism really talks about what's happening within the heart. The most common type of fetal tachyarrhythmia is an AV reentry tachyarrhythmia, and that means a reentry within the atrium and the ventricle. And this has to do with what we call accessory pathways. And these accessory pathways are located in the heart, and these pathways can conduct. In most instances, there is dual conduction, the normal conduction from the SA to the AV node, and also from the SA node to the accessory pathway. And that's why in Wolff, Parkinson, White, you have this type of sign on your EKG. You have a short PR interval, and then you have this upsloping, which is called the delta wave. But in most cases, this is blocked, and so you have normal conduction from the SA node down to the ventricles. You can have several instances. We're not going to talk about this because that's not really important, but there are situations where you can get conduction both from the SA node down to the down through the accessory pathway and then back again. So you actually have a whole circuit through this accessory connection, and you have, and what you're doing basically is bypassing the AV node, so the AV node can't slow the conduction, so you have a tachycardia. Again, this is the most common tachycardia in the fetus. It's seen with a sudden increase and decrease in heart rate. This is an example of time here and heart rate here, and you can see that things are pretty normal, and then there's a sudden increase and a sudden decrease, and this is very typical of this type of tachycardia. The atrial rate can be anywhere from 220 to over the 400, and the ventricular rate is typically 220 to 280. This isn't an absolute, but it can at least give you a hint that that's the type of tachycardia you're dealing with, plus the rapid upstroke and rapid downstroke. There's very little heart rate variability. It occurs due to reentry from this pathway here, the accessory pathway, and we know it as SVT, some cases of PJRT, and even some cases of atrial flutter. How we treat it is basically we slow conduction here, so the tachycardia circuit is broken. So the tachycardia comes around and it comes back up, but this is not working anymore, so the tachycardia breaks and you have sinus rhythm. The second type of tachycardia, besides the AV reentry, is called an automatic tachycardia, and it's very different. The rate is usually slower. It can occur earlier in gestation, and it exhibits what we call warm-up and cool-down. Remember, if you look at this, there's a rapid increase and a rapid decrease. In the automatic tachycardias, it slowly ramps up and slowly ramps down. It only occurs in what we call the long VA tachycardias, and those are sinus tachycardia, some ventricular tachycardias, junctional ectopic tachycardia, and these are very, very challenging to treat, unlike the AV reentry tachycardias. So when you're evaluating tachycardia, as I said, you don't pick up your transducer right away. You get some history from the mother, and this can be very helpful in guiding you even before you put the transducer on to see what you're dealing with. So from the recent OB history, you can figure out what the gestational age is, and it's interesting, but automatic SVT and VT can occur very, very early in gestation. There's even been reports at 10 to 13 weeks, while SVT and junctional ectopic tachycardia really don't happen before 18 weeks, and atrial flutter is much more common in the third trimester. You can also get a hint if you ask when the mother was last seen by the OB provider, and this can tell you how long the baby's been in tachycardia, and that can be helpful in how you approach the treatment. The rhythm and the heart rate at the last visit, and you have to really be pretty specific. Normal isn't really an answer. You have to get the number, because if the rhythm has been regular and the rate has been less than the third percentile for gestational age, and you're now dealing with a tachycardic fetus, you may very well be dealing with long QT. If the rhythm was irregular before, that could be PACs or PVCs, so you could be dealing then when the fetus presents with tachycardia and you see them with SVT or VT. And the fetal movement over the last few days is really important because it will let you know how that fetus is doing. If the fetus has been zooming around and the mother feels lots of kicks and such, then we know the baby's doing well. The past OB history can be very, very important, because if there's been a history of multiple stillbirths and miscarriages and you're dealing with a tachycardic fetus, the mother may have an undiagnosed inherited arrhythmia syndrome, either the mother or the father, because remember, most of those are autosomal dominant, so they have a 50% chance of occurring regardless of the number of the pregnancies. Then the medical and family history. If the mother has a history of rheumatic disease or something like Sjogren's syndrome and the baby is tachycardic, you may be dealing with junctional ectopic tachycardia, which is a tachycardia that utilizes the junction, the cardiac junction, and is an automatic tachycardia. All right, then you get into, of course, your ultrasounds. This you should also ask if there's any medications, pacemakers, defibrillators, or any sort of history of arrhythmia, because again, the inherited arrhythmias are autosomal dominant, and you could be dealing with a baby who's inherited that pathogenic variant. And we don't usually ask these questions. We usually ask, is there a history of congenital heart disease in the family? But that's really just the tip of the iceberg. All right, so then we turn to our echocardiogram. And as we talked about yesterday when we were scanning with Elena, you can tell a lot just by looking at the heart and seeing what it's doing. Here you can see this is obviously an intermittent tachycardia, but if you look at the atrium and then look at the ventricles, the rates are very different. The atrium is not even really beating, it's kind of quivering, while at least the ventricle is kind of beating. So this is intermittent atrial flutter. In contrast, if you look at this picture of this fetus with hydrops, you can see that the atrium is beating at about the same speed as the ventricle. You can also see that the atrium is quite thickened and dilated, which means this is a tachycardia that has gone on for a while. If you look at this picture, you can tell that this is not a normal heart. This is the AV groove here, but there's nothing moving, and that's like the picture that we saw yesterday with Michelle. Here's the mitral valve. You can see the valve flapping around, but there's nothing flapping over here. And in fact, this is down here. The valve is down here, so you know this is an Epstein's anomaly. And we talked about how accessory connections can be part of Epstein's anomaly. This is a patient with some episodes of tachycardia, and you can see that the atrium is quite bright. The AV groove here is bright. The bottom part of the ventricular septum, the atrial septum is bright. This is a patient with SSA antibodies having episodes of jet. And this baby, unfortunately, came along long before sirolimus and rapamycin inhibitors, and you can see that it has an abnormal tachycardic rhythm due to this very large tumor here which is so large you might not even see it the first time, because who would think a tumor could get that large? And then obviously there's some high drops. So Elena contributed a lot of these pictures. We've all had the pleasure of seeing what a beautiful scanner she is. So you'll see some more of them. The M mode is the first really arrhythmia diagnostic tool we use in when we're assessing an arrhythmia, and we put the cursor through the ventricle and the atrium, and we can look at the rate and the AV relationship. In this patient, we note that there's AV block because the atrial rate is very regular here and the ventricular rate is irregular. When you have ventricular tachycardia, you have an atrial rate up on the top here that's slower than the ventricular rate. And I know this isn't really tachycardia, but this was just such a nice example of blocked atrial trigeminy. This is the atrium here, and you can see that every third beat looks different in shape, and that is the premature atrial beat there. The color M mode can also help you. This is a pretty cool technique. I think this is a picture showing blocked atrial bigeminy. The red is the blood moving towards the transducer, and that's the atrial beat, and this is the ventricular beat. So you see there's 2 atrial beats for every ventricular beat. In this situation here, the blue is atrial flutter because the rate is much, much faster than the ventricular rate here, which is seen in red. So that's kind of just a fun technique to do. We talked a lot about this yesterday, so I'll go through it pretty quickly, but just know you either have the inflow-outflow with your mitral valve and your aortic valve, or you have any vein and any artery where you can assess the relationship between the atrium and the ventricle and measure the VA and the AV intervals. Again, these are Elena's beautiful pictures. One thing I think that's really important is that many of you use the cardiovascular profile score to see how well a fetus is doing. We know that in this cardiovascular profile score, one of the big signs of a fetus not doing well is umbilical venous pulsations or retrograde flow in the ductus arteriosus or absent end diastolic flow. Interestingly, if you have a heart rate over 190 beats per minute, you will always have retrograde flow in the ductus, and you can have absent end diastolic flow as you see here. It is a consequence of the rate, not a consequence of any problem with the fetus. If you have a fetus who is going in and out of tachycardia, then you can assess these hemodynamic parameters when the fetus is in sinus rhythm, and if all is good, it should normalize during those beats when the fetus is in normal rhythm. The last way to really assess fetal rhythm, which I wish we had more of these, is by fetal magnetocardiography. This is a device that's recorded without direct contact with the mother. This big thing here is a SQUID device, standing for a superconducting quantum interference device. You can essentially do a fetal ECG at any time during pregnancy, and what you will see are some really amazing things. You can do a signal average tracing, which is this over here, so it's multiple QRS complexes, and you can see the P wave here. You can see the QRS. You can also measure the repolarization. You can measure the QT interval, which, as you know, is impossible by echo. And in this fetus, the QTC was 647 milliseconds, so this fetus does have long QT syndrome. You can look at the rhythm tracings. This is an example of torsade de pointe in a fetus with long QT. That is the French for a type of tachycardia, which means twisting around the points, and we can see how this is really a very polymorphic ventricular tachycardia. Then lastly, you can look at the relationship between heart rate, seen in this top tracing here, and fetal movement. And it's really interesting that right before the onset of tachycardia, the fetus moves, then the fetus is quiet, then it moves again after the tachycardia goes away. So that's something that live-born children don't do. So we'll turn now to the different types of tachycardia. Sinus tachycardia is most often due to a mother who has Graves' disease. Her Graves' disease may have been treated. Her thyroid may even have been removed. But those antibodies, the thyroid-stimulating antibodies, never go away. So the fetus can become hyperthyroid and can develop a sinus tachycardia above 180. And if the tachycardia keeps on going, the fetus can develop heart failure and even demise. The treatment is propyl uracil at any time during pregnancy, or methimazole after the first trimester, because it's not good to give in the first trimester. Sometimes you need a beta blocker such as propranolol to give as adjunctive therapy. Non-sinus tachycardia is either supraventricular tachycardia or atrial flutter, or ventricular tachycardia. For non-sinus tachyarrhythmias, that is SVT and atrial flutter, it's the gestational age and the time that the fetus is in tachycardia rather than the mechanism and the rate that determines the risk of hydrops. And that's pretty interesting, because a lot of people would think that a faster something like atrial flutter, where your atrium is going so fast, would be more likely to cause hydrops. But usually that occurs later in the third trimester, so it's not as likely to cause hydrops. It's really important to recognize the well-being of the fetus, and that's where we really need our obstetrical colleagues, and why you can't really care for these patients if you're a pediatric cardiologist all by yourself, because the type of treatment you give and the escalation of the treatment is going to depend on how that baby is doing. And you're treating two patients plus a family, and if anybody's taken care of a tachycardic family, you know they have a lot of anxiety, and you have to give a lot of tender, loving care. And anxiety is the rule, not the exception. So we talked about the two different mechanisms for tachycardia, the AV reentry and the automatic tachycardia. When you're dealing with these tachycardias, the next thing you have to do, once you've separated into AV or automatic, is measure the VA interval. And we did this yesterday during our demonstration, but I'll just review it really quickly. So this is a picture of simultaneous superior vena cava and aortic arch spectral Doppler. So we have our SVC below baseline, and remember, what we're measuring when we measure atrial contraction is we measure the reverse flow, because that's when the atrium contracts. So this actually is the A wave here, and this is going to be the V wave. So when you use this technique, you should always look for two waves going in the same direction, because again, the A wave is going to be retrograde, so it's going to be going in the opposite direction of the filling part of the wave. So when you get a beautiful tracing like this, it's very easy to measure the VA, which is from the onset of the aortic contraction to the onset of the retrograde flow in the superior vena cava or any other vein. That's your VA interval. And then your AV interval is from the onset of the atrial contraction to the onset of the aortic contraction. And these should both be in your book, so you'll have that to refer to. So this would be a short VA tachycardia. It corresponds to the EKG seen here. And then this is going to be a reentrant mechanism. So rapid stop, rapid start. The long VA tachycardias are usually an automatic mechanism, and you measure them the same way. This time, compared to this one, the SVC is above baseline and the aorta is below baseline. So the VA is from the onset of the aortic pulse to the onset of reverse flow, retrograde flow, signifying atrial contraction, and the AV from retrograde flow to the aortic contraction. So this would be a long VA tachycardia, because this interval is longer than this interval, just like this is a short VA tachycardia here. And again, like we talked about yesterday, if you practice these when you're doing your normal scans, you'll get very, very good at them, because that's really all it takes. Two different mechanisms with long VA tachycardia: reentrant mechanism, which is usually PJRT or VT, and the automatic mechanism, and again showing the difference between how they stop and how they start. This just kind of summarizes the difference between the two, and this is in your book, so I'm going to go on to show some pictures and some examples. So this is atrial flutter. Again, look how fast the atrium is beating, and sometimes if you just kind of cover up the ventricles and look at the atrium and then do the reverse, you can tell the difference a little bit better, but this atrium is going much, much faster. The AV relationship is greater than 1-to-1. The atrial rate can be really, really fast, 300 to 600 beats per minute, but luckily the ventricles can't beat that fast. They can only go at a top rate of about 320 beats per minute. So there is some block, which in this case is good. It can be due to an accessory connection, and you can have SVT and flutter occurring in the same patient, and that's really weird when you see it for the first time because you think you're probably doing something wrong, but really you're not. It can be intermittent or sustained. Sotalol is the first treatment of choice. Let's look at some other pictures. So here's a picture of intermittent atrial flutter. Again, just look at how the atrium are contracting or just kind of quivering. This is an aorta and an SVC tracing of atrial flutter. These are the V waves here. You can see the atrial contractions here. Again, it's retrograde flow, and you can see that there's a 2-to-1 relationship, so the atrium are going twice as fast as the ventricles. This is an example of an intermittent type of flutter. This is the A wave in the M mode here, and then you can see when normal sinus rhythm is restored, both the atrium and the ventricles seen here are at a much more normal rate compared to here. But here you can even see that the atrium are going much faster than the ventricles. So there's an inherited arrhythmia syndrome, which can be responsible for tachycardia and bradycardia in the same patient. So if you're seeing both in one, you should consider that it's an HCN4 mutation. It's better known really for causing sustained sinus bradycardia in the fetus, and it's autosomal dominant. You can see from this family that was in this paper that there are a lot of affected relatives throughout 3 generations. Interestingly, the tachycardia is not a sinus tachycardia, it's actually atrial flutter. This is time on the x-axis here, and on the y-axis this is heart rate, and you see the heart rate is about 110, which is the bradycardia part, and then when it jumps up like this, these are the episodes of atrial flutter. So again, most atrial flutter is going to be due just to reentry, but think also if you're seeing bradycardia that the fetus may have this variant, and you should check for it and look at the family and get a good family history. So another chart about diagnosing the tachycardic fetus, again, really more for your reference than anything else. Who should you treat? Anybody with sustained tachycardia. If you have intermittent tachycardia and you have a good family who's going to listen with a heart rate monitor or come back for frequent visits, then you can get away with not treating them. And when you do treat them, you should treat them in-house. And the reason we say that is it's a lot of responsibility for a mother at home to take her medications. A lot of these medications that we give can cause side effects, and you need to have someone there to support the mother during her treatment. It's also a very stressful time, and there is a very real possibility of proarrhythmia either in the mother or the fetus. And what's proarrhythmia? That means the medication you're giving is doing more harm than good and causing a different type of rhythm, which can be really very serious. So when you admit these mothers, they should have their labs. You should also check their vitamin D. There's a lot of people who are vitamin D deficient, even in sunny states like Nevada and Colorado. If these electrolytes are abnormal, you should do your best to normalize them. A lot of mothers are hypomagnesemic. Magnesium is really important when it comes to repolarization. So you're giving medications that are affecting the cardiac intervals. You want to be sure that there's support for these medications in the mother's electrolytes. She should have an EKG on admission and every day during the loading dose or every 5 half-lives of the drug, because oftentimes the first signs you're going to see are going to be on the EKG. They're not going to be nausea or vomiting, dizziness, syncope, stuff like that. And you actually use the EKG rather than the drug levels to really titrate the most effective dose of medication. Your monitoring should be per your hospital protocol. This is something that you have to make out with your nurses, because the nurses are the ones who will be taking care of these ladies, and everybody has to be on the same page. That's to go with the fetal doptones as well. You need your MFMs and cardiologists to work well together and work frequently together. Fetal echoes are important. Biophysical profile scores are also really important because you can be in sinus rhythm, but you can still be a very sick fetus. And if you don't recognize that, you may not have a good outcome. Give mom as much rest and normalcy as possible. Let her have her kids come and visit. Let her walk around. Let her take a shower. It's really important because oftentimes they're hospitalized for a long time, and you should eat as much chocolate as possible to get through this. All right. So what drug are you going to choose? Well, it's really helpful if you look at whether or not the fetus is hydropic, because you're not only looking at the safety of the agent, you're looking at the speed at which the baby is going to convert. And that's where we feel there's a real role for transplacental and intramuscular digoxin. And we see from these studies, the mean time to conversion was quite high, but when you use various transplacental agents and IM digoxin, you have a much quicker rate of restoring, a much quicker time to restore sinus rhythm. Why? The direct digoxin gets right to the fetus, bypasses the hydropic placenta, and in most cases, and with most medications, the transplacental transfer rate is going to be decreased in hydrops. All right, there's some doses for later. I'm going to skip a little bit ahead because we don't really know at this time what the best medications to give, but in about a year or so we will, due to this handsome gentleman here, Edgar Yagi, who's at Sick Kids in Toronto. He actually devised the first randomized study in the treatment of supraventricular tachycardia called the FAST Registry and the FAST Trial. And these are the results that he has so far. He's not quite done, but he did share them with me. And he looked at treatment of SVT without hydrops, with hydrops, and atrial flutter without hydrops and with hydrops. And you can see that the majority of the patients with SVT and no hydrops were treated with flecainide, with digoxin a close second. And when there was hydrops, combination therapy was used the most. I think the most important part of this, though, is that the highest incidence of poor outcome is with SVT and hydrops, and that rate used to be 20 to 30%, but in this prospective study, it's much, much less, so we are doing something right. The other thing is that the drug-related events are rare. So I just want to close with this picture of a fetus in tachycardia. This mother was seen 4 weeks prior to this visit with us, and I'll show you why in a minute. And you can see there's a lot of ascites here and a pleural effusion. This is the reason that we saw her every 4 weeks, and this is not your imagination. This is the right ventricle here. This is a fetus with hypoplastic left heart. So we were very concerned about this fetus because not only of the tachycardia, but of the structural defect, and also because the baby was not moving at all. So we went to our most potent drug, which is the direct intramuscular digoxin. And what you see here is the placenta. Here's the baby's leg. Here's the femur right here. And here's the needle coming through the placenta and just touching the fetal thigh. And here you can see the needle going in, giving the injection, and the injection is this little area, and then being rapidly withdrawn. The fellows do this. The MFM fellows do this, and they love it. Any tachycardia patient that comes in, they're like, are we going to give IM digoxin? So they have a good time. But this is 18 hours later. The baby converted into sinus rhythm and stayed in sinus rhythm. We continued, though, the transplacental digoxin and sotalol. That is, we gave the drug to the mother. But this baby ended up doing very well and is about 6 years old right now and doing great. So I'll close there because my time's up. Thanks so much for your attention.